Thank you very much for the introduction. Yes, my name is Adam Williamson. I am a senior research team leader here in Brno at ICRC. Today, I'm talking about the topic you just mentioned, this data science topic with sensitive data, human data. So I have organized a talk which will show 4 broad case studies of utilizing a specific type of stimulation. And I think that should provoke some questions related to the sensitivity of the data and how we treat that data. I'll try to make comments throughout the presentation with a focus on that. I think at the end you'll get a pretty good indication of why I've focused on those 4 specific topics. Also, I have a tendency to talk far too long and go way over time. So I am going to set a timer for your benefit, and I will try not to talk more than, let's say, 45 minutes. All right. So the title of this talk is Non-Invasive Electrical Stimulation for the Central and Peripheral Nervous System. That's cool, and we'll look at why it's cool to have a non-invasive stimulation system. But at least in the context of the topic that everyone here is interested in, you'll see an extraordinary dichotomy between non-invasive and invasive in forms of previous forms of stimulation. And if you're talking about sensitivity of data, often the amount of data you're going to need from patients if you're looking at an invasive surgery is wildly increased compared to, let's say, outpatient style stimulations or solutions that are completely non-invasive. So that'll also be highlighted, I think, throughout some of these slides. Okay, so every good presentation needs an outline. This, I hope, is a good presentation, and it has an outline. I will start with broadly some topics in epilepsy. Because of the topic of data, I included very quickly some preliminary animal results that will introduce the method. And if anyone has questions about like extensive work with non-human primates or rodents or something like this at the end of the talk, I'm happy to answer those. But I did not include a lot of animal studies. I just wanted to focus on 4 broad human categories. So we'll start with epilepsy. We'll move on to tremor and Parkinson's disease, and that will conclude the central nervous system stimulation portion. Then we'll go to clinical applications in the periphery, in peripheral nerves. We'll look at something called the hypoglossal nerve and something called the vagus nerve. And then concluding statements will probably just be me showing a team slide and saying thank you very much. So temporal interference. We're going to set the context for the entire talk. Probably, maybe some of you have talked about bioelectronic medicine, the idea of taking points of electrical stimulation and replacing broad drug therapies. So this slide is specifically illustrating situations in epilepsy for our patients, but can broadly be used as a guideline in basically every situation where you have a pathology in the brain and by extension in peripheral nerves. That meaning, step 1 from most of the clinicians is going to be to prescribe some type of a drug therapy. These are, in the case of the central nervous system, taken orally most of the time. They're diffusing everywhere, as depicted in this picture. This is valproic acid. This is an extraordinarily powerful seizure medication. There are all sorts of very unpleasant side effects for our patients. Additionally, 30% of patients are just simply drug resistant. And so you see this type of phenomenon in all sorts of other cases of health and disease, right? So 30% are drug resistant. Another 30% are easily having side effects that are extraordinarily unpleasant, affecting quality of life. So it's not really if, it's when drugs fail. The gold standard solution for epilepsy is intracranial electrodes, the so-called SEEG electrodes. So these electrodes are then inserted in many, many places in the brain. And from these electrodes, we apply stimulation and we record to try to identify the so-called epileptogenic zone, the zone of the brain that is responsible for the seizures. And the gold standard solution, believe it or not, for those of you who are not familiar with this, is a very large resective surgery. Once the epileptogenic zone has been identified, a portion of the brain is then resected, is cut out. And as you can imagine, significant deficits can be associated with a resective surgery. You may have seizure freedom, but the deficits can be, let's say, significant cognitive deficits, as up and to the point of not remembering who you are, right? There are some solutions in point 4, and we'll come to some of these because these are going to be our targets in terms of taking invasive stimulation and turning them into non-invasive stimulation. There are some permanent implantable invasive stimulators. Broadly, they have been totally ineffective in epilepsy, let's say with efficacies of maybe 15% reduction in seizures, up to perhaps 50%, depending on the case. So they haven't been effective. What we'd like to talk about today then is a situation where in all of these modes of health and disease, we could take a form of non-invasive stimulation and dramatically increase the amount of explorable brain tissue or peripheral nerve tissue, patient tissue, and thereby refine the estimation of the target and then resect a significantly smaller portion of the brain so that you would have seizure freedom and, let's say, minimum to no deficits. That'll be a theme that's going through here, is minimization of the invasiveness while maximizing the output at the end. And I would just comment and say, although this second point looks invasive, and on another slide it'll look very invasive, and it is, you really don't have much brain coverage. There's all sorts of brain regions that are involved in cognition, speech, motor. You just can't put electrodes into every part of the brain. Additionally, there's parts of the brain that are significantly dense with capillaries and vascularization. If you start pushing electrodes in there, you'll have intracranial bleeding. So having a solution that's non-invasive is going to increase the well-being for everybody in this scenario. Okay, so what is going to be the solution? We're coming to this topic of something called temporal interference. This is going to be a combination of our expertise at ICRC using these intracranial electrodes where we stimulate and record and map, and we take our patients and identify this seizure location. We're going to combine this with something that I have created called temporal interference, where we take two high frequencies, in this case F1 and F2, that are kilohertz frequencies, and they're going to combine in space interferentially to create an envelope. And we've shown that this envelope is very focal and is utilized to create forms of deep brain stimulation. So totally non-invasive deep brain stimulation, at least in the horizon of epilepsy and some of these other indices that I'll show you today. So how does that work mechanistically? This is a talk that has a very broad audience, so I have not loaded this with a whole bunch of math and physics. We're going to treat the stimulation this simply. We're going to say previous iterations of stimulation, at least non-invasively, used, for example, a pair of electrodes, like in blue. They would put a pair of electrodes on your head and stimulate at a frequency F. Great. In our version, in the simplest version, we're going to use two pairs of electrodes. One is stimulating at F, but F is no longer a low frequency of traditional utilization. Let's say it's not 5 hertz, it's 5,000 hertz. 5,000 hertz just passes through tissue. It's not evoking any activity from electrically active tissue like neurons or nerves. We'll take another frequency at 5,000 from the black electrodes, but we'll add a slight offset. So let's say 5,005. Now, at a deep brain point that is broadly related to the geometric orientation of those electrodes, we'll have a deep brain focus that will be stimulated at the offset frequency. It's at that so-called envelope or beat frequency. I think everyone has had enough math classes to know if you add two sine waves together, you create a situation where you have a sine wave that is oscillating, right, with that offset. Those two waves, black and blue, are coming into and out of phase at a rate equal to that delta F, that offset frequency. And so that's the end of the physics lecture. We're just going to use that going forward, saying the envelope is a phenomenal, non-invasive tool for patients. Okay, so before we get to our patients, we just do a very fast, let's say, historical precedent to get us to the patients, and that's the development of this over the last few years using animal models, specifically epileptic animal models. So we want to show, or at least illustrate for you, that you can do multiple things with different envelope frequencies. So here, excitatory stimulation. We want to provoke activity. In the case of provoking activity, let's take our mice, our epileptic mice. They're very cute. They're very cute epileptic mice. This is no exception. This is a very cute epileptic mouse. We have an arrangement of topical electrodes, and you can see we're using 1,250 and 1,200, where the offset is going to be 50. So we've arranged it such that this one specific deep brain structure is receiving a 50 hertz stimulation, but there's no implant. There's no electrode in the mouse's head. Similarly, we compare this with a traditional 50 hertz stimulation, where you just put one pair of electrodes on the head. And even just from simulations, you can probably predict this is not going to work. You can see from the results, we are able to focally evoke seizures in this mouse. That's what we wanted to do in the patients. We want to evoke these seizures and track them. We can do it in the mouse. We evoke seizures. And if you use traditional methods, it's absolutely not going to work because you just don't reach those deep brain structures. So that's excitatory stimulation. We've taken our knowledge from the patients. We know that excitatory stimulation is, just take my word for it, or the previous publications, it's 50 hertz. And then we've cloned it and done a totally non-invasive evoking of a seizure in at least a rodent model here. So never been done before, done here. So let's do an inhibitory stimulation and do the reverse, where we take the epileptic activity and we suppress it. We just switch the envelope. In the patients, you take a higher frequency, something typically over 100 hertz, here 130 hertz. So you stimulate at this higher frequency and it suppresses epileptiform activity at the target. Here is an example of interictal spikes. These are the pathological spikes that are happening regularly inside these deep brain structures in our epileptic mice. These yield, in aggregate, huge brain-wide seizures, right? The more of these spikes are present, the more you evoke some of these seizures. So the idea is, if you suppress those, you suppress seizures. That is, in fact, what we do. We perform this. You can see we've switched the frequencies to give us a different offset. That's how this method works. All you do is change the radio frequency. Now the offset is 130. That's the inhibitory frequency we know from the clinic. And the result is that the rate of these spikes is completely suppressed. And perhaps more interestingly, the form, the amplitude, area, duration of these spikes is totally suppressed, such that it becomes anecdotal. Like, do you count that as a spike or no? Because they're all totally suppressed. So the animals have no seizures when you have this type of therapeutic stimulation. It's essentially no longer an epileptic animal at that point. So that's great, but an observer doesn't need to be paying too much attention to notice that my very cute mouse is a lot smaller than this epileptic patient, right? So we scale it. And typically when you're scaling in some of these early technologies, again, this has come to the idea of like ethical applications, human data, things. There's a sequence. You typically go from rodents to non-human primates, and then there's usually some phantom issues in there. For the sake of time, we'll avoid the non-human primates. It's a replica of what you just saw with the rodents. But we go to human phantoms. This is where you take cadavers. So we literally book many, many cadavers. Neurosurgeon in my group takes the cadaver and implants the cadaver with the exact same electrode arrangement that you've been seeing on previous slides in these human patients. We target, for the sake of continuity in this talk, we take the same deep brain target. It's called the hippocampus. So we target that specific region, and we see that we take a pair of electrodes in blue, a pair of electrodes in red. We're targeting that specific hippocampus region. It's outlined there. And if we just look at the envelope frequency, we can say, oh, that's extremely focal to the anterior portion of the hippocampus. And that was what we'd calculated. And that's what we'd hoped to be focal to, was the anterior portion of this specific brain structure. Anecdotally, let's look at one of those electrodes. So we look at one electrode right through the side of the head of the cadaver, and we're going to look at the amplitude of this modulation. You can see that for this TI, this combination of high frequencies, very shallow in the head, let's say electrode 8. So we're coming down through the cortex. That's an example electrode. So contact number 15 is at the very shallow portion of the head. We're going down 11, 10, 9, 8, 7, et cetera, all the way down to 1. 1 and 2 are in that deep brain structure. It's very deep, are in that structure. You can see that as we traverse the electrode, we have more and more amplitude modulated signal. And we would associate this with maximum stimulation. Whereas for that traditional frequency, when you apply it directly to the scalp, you can see that the maximum modulation, just the frequency itself, is very shallow in the cortex. And as you get deeper and deeper and deeper, that amplitude is just decreasing. So if you want to have the same amplitude of stimulation at the deep target, using a traditional method, you need to overstimulate everything all the way down to the deep target. And then I don't know how you interpret those results, because you're overstimulating so many, let's say, relevant and irrelevant brain structures simultaneously. The results would be incomprehensible. So we don't do that, also for some other reasons that we won't get into in terms of like density of current and pain. So using these specific results, we did our first human pilots, where we took epilepsy patients. And you're talking in this context about data safety. All of this needs to be anonymized. All of this needs to be on secure servers at the hospital, et cetera. To do this correctly, we do modeling, patient-specific modeling. So we create an electrodynamic head of the patient using their MRI and their postoperative CT. All of that has to be anonymized and then put on secure servers, so that, for example, one of my students can do all the simulations, but at the same time, shouldn't be able to identify the patient, right? But it's absolutely critical that we do this type of modeling to make sure it's patient specific. We have to know exactly where those patients' intracranial electrodes are. So that's all anonymized. We perform the stimulation. We create an estimate of where these stimulation electrodes need to go. Then myself, one of my staff, go perform the stimulation. And fantastic, in this first set of patients, we have a total suppression of spike rate. And then just like you saw in those rodents, the actual character of the spikes, the area, duration, amplitude, totally suppressed, and very rewarding to be at the nurse's station. We do this now regularly here in Brno with the neurologist, and the neurologist says, Adam, with spikes of this size, my patient is absolutely not going to have a seizure. So you say, it's a total therapeutic suppression of the participant's epilepsy with absolutely non-invasive electrodes. So that's the status. There's some other, like, let's say, more complex portions of the projects that we're doing with epilepsy patients. But broadly, I think that's a pretty good introduction into the difference between the invasive and non-invasive concepts of stimulation, in particular as it applies to the central nervous system, and then the complexity as we start to get closer and closer to the human data and what we need to do with that. I would say anyone that probably has questions about the human data treatment, we do that at the end, or you could interrupt if it's allowed. But I would say I'll leave it like that as an introduction to the epilepsy situation and where we are with human data, and move to our next topic, which is tremor and Parkinson's, because here the patients again are going to necessarily need to give us their MRI, their postoperative CT, and then in these cases we're going to need detailed patient data about the Parkinson's patient and about their specific form of tremor, right? So then this is everything from age to medical background. In the case of epilepsy, some of that is less relevant, right? So let's look at the brain of a typical tremor patient. What we're trying to do is hit two specific structures in the absolute center of the head called the subthalamic nucleus. It has bilateral on the left and right side. Some of the work we're doing right now, it's going to be using that inhibitory frequency of 130 hertz, very much like that epilepsy here. So we have 9,000, you can see from the yellow, and 9,130, which will give us an overlap that creates that 130 hertz envelope that we believe is causing this aphagasy, okay? So what's happening in our patients specifically? Brno is very unique. There are only a few places that do this, and that's that the implant of a patient's deep brain stimulator for Parkinson's and tremor is done in steps. Most places do this like you're ordering and getting takeout from McDonald's. It's just the person comes in, boom, stimulator and the wires and the battery, and then you send them home. Because of the interest in parameters of stimulation that we have here, we have a process called externalized DBS. So this is the end result of the second step. The first step is simply the implant of the stimulator. The wires to the stimulator remain exposed for approximately 24 hours. So the patient's contacts to the actual electrodes deep in their head are available for us to make contact with and, let's say, investigate stimulation parameters, or as you'll see here, investigate temporal interference. So in an externalized DBS, this is a zoomed in portion of the patient's head. This is a patient-specific postoperative CT. You can see the subthalamic nucleus is a piece of neurology where many, many experts, far better than me, could tell you all about the small minutia of the subthalamic nucleus. From the engineering standpoint, to stop tremor, orange is good. And it's that straightforward. And that's how the engineers treat it as well. You look at the postoperative CT and you say, okay, I think electrode 1 and 2 are probably not as good as 3 and 4, because 3 and 4 look like they're very close to the orange is good region. And that is exactly how it's done. You look at a patient's postoperative CT, you take a look, we test all the electrodes regardless, but it is very probable that in this specific case, we could rotate this in 3D and see that the top 2 electrodes are going to be preferential for this specific patient on the right side. And on the left side, perhaps contacts 3 and 2 in the center would be ideal. So we're going to take these electrodes now. We're going to, instead of stimulating from them, we're going to connect them to a recording system. We're going to put transcutaneous electrodes down, and we're going to stimulate towards this patient's subthalamic nucleus and see if we can non-invasively control tremor. Recordings from those electrodes, from those 4 contacts, indicate that we see TI. We see these envelope modulated signals at the location. So the question is it effective in reducing tremor? So the parameter of interest is going to be, interestingly, variable between participants, depending on the degree of tremor that they have. So in this participant, the tremor was not nearly as significant. So if we look at the indication for tremor, which is called beta, just take my word for it, beta. It's a frequency just above 25 hertz here. In blue, with no stimulation, the patient has a visible pathological beta. With both deep brain stimulation directly from the electrodes in orange, and then non-invasive temporal interference towards the focus, we get an identical result. We suppress beta to some degree. You say, well, it didn't go to zero. They didn't have much tremor to begin with. So let's take a more extreme case. But this is at least, let's say, promising, right? Because we've cloned the results of the invasive electrode without the use of the invasive electrode. So we take one of our patients, again, all of this is going to come back to the anonymization of data and protecting the patient's identity, in addition to all of their medical records, making sure that the patient's not discernible from the photos that we share, even internally, technically, legally, only the physician is supposed to be able to identify this patient. So what we do is we take an arrangement of these topical electrodes. This is a very cool time to introduce this. We have these non-invasive high-density caps that we have, and we put these caps on our participants, and we can select all sorts of combinations of electrodes to do this type of stimulation towards the patient-specific deep brain target. So in this gentleman, the tremor was significant, a very significant tremor. So again, we look at the postoperative CT, we make comments on what electrodes we will use in terms of the direct stimulation from this participant's deep brain electrodes. We again look at the recordings when we're ready for TI to see that we are in fact reaching that specific deep brain structure. And for a gentleman who has significant tremor, you can see a massive, massive peak at beta. Suppressed medically, very well suppressed with the implantable DBS, right? And in this case, only using 2 frequencies, we get about a 50% reduction. So you can see in this non-invasive method, I won't go into the other methods where we create multiple envelopes and try to drive this frequency down lower. That'll involve some of the physics and math, which is probably, it's irrelevant for the topic for today. But you can see we're already, let's say, in the game where we have a totally non-invasive pair of electrodes and a pair of electrodes, and we're also suppressing tremor in a patient that has really bad tremor. So would I then recommend them to have only non-invasive stimulation? No, but we can already take this non-invasive method, stimulate toward the target, reduce tremor, and then tell the patient, hey, congratulations, you're an awesome candidate for an invasive implant because we just showed electrically that you're responsive to this type of stimulation to suppress your tremor. So that's already, I'm very, very proud of that result. I think that's an excellent win. And we'll just go ahead and continue to iterate on this to make it more focal, suppress even harder, and replicate some of those DBS results in the Parkinson's patients. So with that, we are concluding at least this introduction to this type of stimulation in our patients at the hospital using central nervous system stimulation. So arrangements of electrodes on the scalp and skull to provoke some type of activity deep in the brain. So what we want to do now is transition to peripheral nerves, because peripheral nerves in our body are also electrically active. And there's no reason that the things that we take medication for, bringing this back to my very first slide, the things we take medication for to treat disease, there's no reason we can't also replace those medications with focal points of electrical stimulation for these peripheral nerves. So that in CNS, we go to these peripheral nerves. Okay, what are we looking at? We have some primary targets here. Let's start with the vagus nerve. The vagus nerve is an extremely important nerve in everyone here and is located directly along your carotid artery bilaterally. This is a very graphic but very telling photo of the vagus nerve with an invasive implant on it. This is a publication from Operative Neurosurgery with us. This is the neurosurgeon who did those deep brain implants in the cadavers. This is one of his more recent publications. He's describing in this paper some interesting methods as to how you can rearrange the swabs that are involved in the placement of these electrodes and how his method is, let's say, reducing to some degree some inflammation. Yeah, but what are we doing? The neck is completely open. The carotid artery has been separated from the nerve. They're wrapping electrodes around the nerve. It's indescribably invasive, extremely dangerous, right? You need a very competent surgeon to be able to do this. And this is one of the methods that controls epileptic seizures, is you put one of these on the neck, right? You put one of these in the neck. So our idea is, can't we do it with non-invasive electrodes? Can't we put this in, at least for the well-being of the patient? And then you just don't need the same significant invasive nature of interrogative data and then also the surgery itself. So can we do this with transcutaneous electrodes? Let's start with a simpler peripheral nerve target rather than go right for the vagus nerve, which is connected to the thalamus, which has a relationship to the heart. So we take something basic, where the biomarker is very, very straightforward. So we start with the hypoglossal nerve. Hypoglossal nerve is located in your face, under your jaw, and is controlling the protrusion of your tongue. You'll know the nerve better than you realized because it's the primary focus of sleep apnea, specifically obstructive sleep apnea. So somebody here has for sure seen, because there's so many people with obstructive sleep apnea, a PAP machine. PAP machine is currently the #1 treatment for obstructive sleep apnea. It essentially functions like a leaf blower pushed into the mouth of the person. So while they're asleep, it shoots air into your mouth and blows your tongue out of the way and opens an airway. So obstructive sleep apnea, the hypoglossal nerve is, let's say, ineffective. Your tongue loses tone while you're asleep. It falls into your throat. It closes the airway, and you're startled awake, and you wake up feeling terrible because you had terrible sleep because of this continuous blocking of your airway. So the PAP machine is, at least at this point, one of the more effective ways of moving the tongue out of your throat as you're asleep. However, the patient adherence to this technology is somewhere below 40%. You can give someone a PAP machine, they're uncomfortable, they're noisy. If you're married, your bed partner hates you, hates the noise, like people just absolutely will not use the machine. They'd rather have an extraordinarily low quality of life, being very overtired, than ever use this machine. I kind of don't blame them. It's super annoying. Okay, so what are we doing? We said we're taking invasive technologies and attempting to replace them with a non-invasive technology. There is an invasive device. So in the spirit of capitalism, some people that were previously making vagus nerve stimulators for epilepsy, right, had the idea that you could take an invasive nerve implant and put it on the hypoglossal nerve. So it's essentially, now the technology has advanced a little bit, but originally it's a repurposed vagus nerve stimulator, right? So they put this on the hypoglossal nerve in an extremely complex surgery where you have to separate portions of the hypoglossal nerve, target only the portion of the nerve that's causing the protrusion. Then you locate a battery in the chest, just like our Parkinson's patients. And then you locate some sensors in the intercostal tissue between your ribs, okay? This is just because you have obstructive sleep apnea. That's a bit of an aggressive solution for having sleep apnea, right? It is, however, really effective. You do activate that nerve. And what happens is when you activate that nerve, the tongue protrudes. So the way the device function is you go to sleep, it turns on, and it starts activating the nerve, and your tongue starts returning with tone, and it never falls into your throat all night. It turns off when you wake up. Great. But it is kind of insane that you'd have so many people, you have an invasive surgery, there's not enough surgeons in the world to get every person with this disease implanted with the device. So a non-invasive component would be, let's say, desirable. So that's what we do. We start out with some patient-specific or participant-specific stimulations. We're able to see that arrangements of skin electrodes on the chin can, in fact, activate the hypoglossal nerve very, very effectively. We then look at a scenario where we have our electrodes in place and we have nothing on. The tongue is now in the back of the throat. If we have our non-invasive stimulation on the left side or on the right side, it causes lateral protrusion of the tongue. And it does so very, very effectively, actually. It'll come out to the left and the right. Interesting caveat, the invasive device is not bilateral. It's unilateral and causes the tongue to move out to a specific side, which has been, let's say, internally shown to cause a sidedness to sleep. The device is less and more effective depending on what side you're sleeping because of the lateral protrusion. So what we do is we use a symmetric placement of electrodes on the chin, and we create a central protrusion of the tongue, which gives us a non-specific sidedness. So our device is equally effective back, left, right side. So great. How does that work in practice? In the preliminary experiments that we had with an IRB approval, in this case, we had to go through the United States. It's as easy as taking silver chloride electrodes that are gel assisted and kinesiology taping them to the face. We then create arrangements of electrodes that give us those envelopes we looked at. We said excitatory was 50 hertz. So this is equally excitatory, 50 hertz. So we take our stimulation and we evoke activity in the hypoglossal nerve. And when it works, it looks as dumb as this video, which is this gentleman is being stimulated and his tongue starts moving out of his mouth. And if you do this, it is extremely bizarre feeling. You have the sensation that your tongue is coming out of your mouth, but you had no mental, you didn't force that to happen. It's just happening. Your tongue is moving out of your mouth without you even knowing it. So in that case, when the participant goes to sleep, the tongue just starts moving and we just move it out of the mouth, right? Let's say not out of the mouth, but against the teeth, right? Very similar to the invasive implant, but here simply with some kinesiology tape around the chin. Long term, we have some very nice grant officers who are helping us put together some projects to have funding for this in a further iteration where we will develop devices that look significantly sexier, but at the moment it works just fine with kinesiology tape. So how does that look if you look at the data? Well, at the moment in its first iteration, after the first human study, anecdotally, we see person goes to sleep, they're being monitored in a sleep lab, all of this chaos, this is fluctuations in blood O2. So this is an indication of these apnea events when the tongue is falling into the back of the throat, the person coughs and is losing, let's say, blood oxygen due to the airway being blocked. So you see, once the device is on, there is at least anecdotally in this one picture, a significant reduction in the number of apnea events. Because it's just a sticker of electrodes, the person can wake up, they can go to the bathroom, they can come back, they can take the sticker off, they can put the sticker back on, it's not a problem. They go back to sleep, we reactivate the device. Again, apnea events are significantly decreased until we decide to turn it off at the end of the night. You can see apnea will return. In the case of women, it absolutely totally seems to just cure sleep apnea in women. It just works. Women, it's wildly successful. In men, we're at about 50-50. So some men are responsive, some are not. We have some further projects that are iterating on the number of envelopes, the number of electrodes and things like this to address that. It seems to be more effective now in men. And so let's say, hopefully if I'm here again, I'll show you some data that shows how it's now 100% successful in men. Regardless, I mentioned this device downsize. So we're making devices that will give the clinician, and now here you come to this idea of data, we have to have the clinician able to monitor the patient's sleep data continuously. So we have a patient portal that we've created or are creating so that that participant's sleep test overnight at home every night and results of the stimulation are going directly to the physician. And perhaps more importantly is adherence. So the physician can then also monitor adherence. And there you kind of go, that's a bit big, brother. We're like, yeah, it is, but we're doing it anyway. It's, we can talk about that. But in the case of those PAT machines, people just don't use them, right? We know because everybody, all of these like daily life parameters, everything all the way up to blood pressure is terrible, yeah? People don't use them. Here, we would like to at least be able to talk with the patient about why they're not using the device they've been prescribed. So there's an adherence portion that is in the portal for these new, let's say, next wave of devices. Okay, that said, I would make a quick note to career highlight. I think this is fantastic in the topic of humans and human data. This device that we have received a breakthrough designation from the FDA. So that's kind of amazing. I will just read off my slide. I don't normally do that, but I'll just read off my slide. So of the 760 devices given breakthrough designation since the program started in 2015, only 7 have been under the ear, nose, throat, ENT category and 0 for sleep. So we are the first device that the FDA has ever characterized as a breakthrough device in the case of sleep. Why is that important? Because everybody can submit a dossier to the FDA. Anyone can do that and say, I want to get an FDA approval for my device. It takes years. If you are designated as breakthrough, it's guaranteed less than 6 months that you have a report back from the FDA. So when we conclude our pivotal study, ideally funded by some of these upcoming grants, we hope we get, we will be able to speak with the FDA in less than 6 months and have a response to the results of our pivotal clinical trial. So it's very exciting. And I come to the end of this peripheral nerve, and it looks like my time is, we're going to be right on time, is the vagus nerve, because we introduced the peripheral nerves with that very graphic picture of the very invasive stimulator that is being used for the vagus nerve. So this is an example of a non-invasive stimulator, and someone is holding it next to their neck. From what we know from the previous results that I showed where low frequencies just don't penetrate, you could perhaps already guess that I don't feel real excited about this specific device. The gammaCore device is approved for things like headache in the US. Whether or not it does anything to headache, I won't comment on. But the issue is in epilepsy, we have people that are being selected for an invasive vagus nerve stimulator to save their life because they are a good candidate to have a vagus nerve stimulator. Then they do a little bit of Googling and research it, and they come up with a non-invasive device like this that they buy a prescription for because it's not covered under their own insurance. So then we have a situation where a patient with massive uncontrolled seizures is now self-treating themselves with a toy, holding it to their neck, thinking that they're somehow reducing their seizures, right? So this is the type of, let's say, scenario we're in with the other non-invasive stimulation technologies. So we're going to venture into this specific category now. So let's compare this to the idea of putting some of these mixed high frequencies on the neck to also target the vagus nerve. So we come back to that operative neurosurgery publication, and we want to test if we can hit the vagus nerve. So let's not do it during the surgery. So the top picture is during the implant of the electrodes onto the vagus nerve. The bottom picture, you can see the lady's neck is perfectly fine. There's nothing wrong with her neck. This is years later. So this specific woman is participating in one of our initial studies using the vagus nerve. So she has come for a battery change. And we decided this is the best time to attempt to prototype the use of TI versus low frequency stimulation targeting the vagus nerve. How does this work? The battery is going to be explanted from her chest and replaced with a new battery. So what we're going to do is arrange electrodes on this specific participant's neck. I've done this a few times now. And then wait for the surgery. This on the left, this is the surgeon from my team or from my previous team in France. He then makes an incision. He removes the battery from the participant's chest. He then disconnects the battery from the actual connections to the battery. And just like the explanted DBS that you watched for Parkinson's, we can now make contact to those wires and essentially turn the stimulator, just like in the Parkinson's, we turn the stimulator into an antenna, and we're going to measure directly at the level of the vagus nerve because there's electrodes on it. So that's what we do. We take those, we make contact with those. It's all done under sterile conditions. So we're now recording from the previously implanted stimulator before we switch the batteries, right? So then we also contact those electrodes on the neck, and we make some stimulation experiments towards those electrodes. So when we're finished, we just disconnect, reconnect to the new battery, and it's as easy in the video. You just push the battery back in place and you sew the person back up, and they can go home with an effective running vagus nerve stimulator. What do the results look like? The results look like this. If you stimulate with high frequencies, let's say 2000 and 2005 hertz, you see in the power spectral density of the recorded signals from those electrodes, you see the two peaks, you see the two frequencies that we did with TI. If you stimulate with a low frequency, specifically 5 hertz, as advertised by some of these toys, we don't see the 5 hertz. It's just not there, which means if the other devices that are using low frequencies, and we watched how poorly that penetrates tissue, if it's curing epilepsy, it's certainly not doing it with an electric field because we don't see the electric field at the level of the vagus nerve. So that also makes me personally very, very angry, and it makes my surgeon colleagues very, very angry because we have these participants that are still using some of these devices that are advertised, but are clearly not effective. So where are we going with this now? The first device we've, let's say, targeted or indication in terms of vagus nerve is not actually epilepsy related due to the complexity of epilepsy. So what we're going to look at is, we looked at the Inspire device. That's the one for hypoglossal. We're looking at the SetPoint Medical device. So SetPoint Medical is a very nice, very slim vagus nerve stimulator. But again, although small, you can see here, about the size of a coin, you require very skilled surgeons to implant this in place. So similar to the obstructive sleep apnea, we have patient populations in the billions. This device is used for inflammatory disease, where you have, it's like cardiovascular disease in general. You're looking at billions of people with this issue. Even mild cardiovascular disease can lead to extraordinarily low qualities of life, early death. So this device, what it does is stimulates the vagus nerve, which then in response activates splenic nerve, which then in response creates a reduction of inflammation via the reduction of blood cytokines. So anyone that's ever studied any inflammation, you have things like blood TNF, IL-1, IL-6, all of these indications for inflammation. The standard way of treating inflammation is that you eat anti-inflammatory medications, right? But those medications are completely artificial. There's no evolutionarily developed process for us to deal with medications that are systematically targeting individual cytokines. You eat a medication for TNF, it'll take blood TNF to 0, right? 0. If blood TNF goes to 0, your risk of infection is astronomically increased because you have no inflammation. You have no ability to create inflammation to fight infection, right? So what the technology here does, and it does it really effectively, is it activates the vagus nerve, which then broadly activates all reduction of cytokines, but it can't reduce it more than approximately 49, 50%, right? Because there's no evolutionary mechanism inside of us that would allow activation of a specific nerve to somehow take our ability to fight infection to zero. It can reduce inflammation, but not take it to zero. So it's very, very effective at treating inflammatory disease, things like Crohn's disease, rheumatoid arthritis. And we have an ethics approval now here in Brno to treat Crohn's disease with the non-invasive version of this. With the first results being presented in this moment, we take human participants, we take an arrangement of electrodes on the neck, we target the vagus nerve, we stimulate, and at least preliminarily in participants, we can see that we can cause a very, very accurate, very controllable drop in heart rate, approximately between 5 and 10%. We don't want anything more. You don't want the person falling on the ground. But we controlled decrease of the heart rate using this vagus nerve stimulation. So with this, we will, in the next couple of weeks, launch a stimulation set of experiments with, let's say, trials with some of our Crohn's disease patients, and hopefully replicate exactly what's been done in that previous invasive stimulator that you just saw, the SetPoint medical device. So I said I was not going to talk more than 45 minutes, and it looks from my timer that I am approaching 40, so it was 40 and change. So let's just go to the conclusions then, which is, I hope, coming back to the very first slide, in some of this, I have touched on some of the issues we have in terms of, at least you can infer, with patient data safety, because we have a lot of patients and a lot of different projects and a lot of people working on those projects, and you have to be very careful with people's identities and data. And I hope that I've also convinced you that with some of these combinations of envelopes that we really do, at the very least here in Brno, possess a completely and totally non-invasive deep brain stimulation. At least we possess it for epilepsy. And then I hope you were convinced of some of these other indices. So let me say thank you to some people. So our team, there's me. We have 4 postdocs here right now. We have 6 PhD students. I just show the slides. Really, they do all of the hard work. So thank you very much to them. And I would also say I am traveling currently back and forth between here and Sweden very often. So I would say thank you very much to 3 of our very good collaborators at the Swedish University as well. In terms of funding, we are funded by the ERC, by the EIC, and by DARPA. And our collaborators include things like the University of Wisconsin, Emory University, UC Davis, the lovely people at ITIS in Zurich, Imperial College, with my colleague and collaborator Nir Grossman, and the Karolinska Institute in Stockholm. And with that, I would say thank you very much for your attention.